So yes, now the topic is treatment of Alzheimer's disease. So in the last class we have discussed what is Alzheimer's disease, what are the signs and symptoms, what is the pathogenesis behind it, and what are the clinical findings, and how we'll be identifying or detecting the diagnosing this Alzheimer's disease. All those things we have discussed. Okay, now today in this class we'll be discussing treatment of Alzheimer's disease. So this is a picture showing this prevention, how to prevent this Alzheimer's disease. As we already know that this is seen most commonly in old age and obese and who are having other alcoholic habits. So in order to remove all these things, and it mainly involves the memory process. So we have to do some kind of activities which will activate our brain continuously. It includes swimming group sports, playing games and walking. So all of this will keep our brain active. Playing musical instruments, learning foreign languages, reading and writing for pleasure. So all this will help in preventing this Alzheimer's disease. Why? Because there should be a continuous process of learning so that our brain will be continuously active. Coming to this treatment, the first and foremost goal, what we have to discuss is what are the different goals of treatment. So first goal of treatment in Alzheimer's disease is in order to maintain functioning as long as possible. That means we have to maintain the functioning of our brain as long as possible, and also we have to treat the psychiatric conditions and behavioral changes. If at all if there are any psychiatric problems that we have to treat, and also we have to change this behavioral sequel. And then for mild to moderate Alzheimer's disease, if the condition is very mild to moderate, then we have to go for cholinesterase inhibitors. And so initially we have to give low dose of cholinesterase inhibitor, and slowly gradually we have to increase the dose, that is titration of the dose should be done, and then we have to keep a patient on maintenance dose. This is the thing which we follow for the patients who are having mild to moderate Alzheimer's disease. Okay, and then coming to moderate to severe Alzheimer's disease. So along with this cholinesterase inhibitor, we have to give memantine. So both combination of drugs should be given, cholinesterase inhibitor and memantine. And initially here also low dose, and then we have to titrate the dose and we have to maintain the dose. Alternatively, consider memantine. So if it is not possible to give this memantine and cholinesterase inhibitor in combination, sometimes the physician may prescribe even at least memantine alone or cholinesterase inhibitor alone also. And also along with this, apart from this, we have to treat the underlying, the patient is having what are the different psychiatric symptoms, behavioral changes. So depending on that, we have to give other medications and use pharmacological management only if necessary. That means if at all, if the patient can be maintained on any counselings, psychiatric counselings or any other changes like non-pharmacological treatment, then it's better to go for those. And if at all if all those fails, then only we have to go for pharmacological treatment, okay, for any behavioral changes and psychiatric symptoms. So main drugs include cholinesterase inhibitors and memantine. So for mild to moderate, only cholinesterase inhibitor is sufficient, and for moderate to severe, it requires the combination of memantine. And then non-pharmacological therapy includes sleep disturbances. So if the patient will be having the symptoms of this sleep disturbances, so we have to correct that. Wandering, urinary incontinence. Urinary incontinence include urinary incontinence. That means the patient will be maturing without any consciousness, agitation, aggression. These should be managed with behavioral and environmental interventions whenever possible. That means when the patient is having these kind of symptoms like wandering, urinary incontinence, agitation, aggression, sleep disturbances. So at that time we have to make changes, behavioral and environmental changes. So for these we no need to go for medication. So it's better to maintain the patient on these behavioral and environmental changes. And then on initial diagnosis, the patient and caregiver should be educated on the course of illness. So here we're not only giving education to the patient, but we also have to inform We also have to inform all these remedies and all these measures and how to take medications, what are the precautions to be taken. All these should be explained in detail to the caregiver also. Okay. And like how long the duration of the treatment will be there and how could be the prognosis of the patient having this disease. All these should be explained to both the patient and also the caregivers. And also not only that, we have to tell about course of illness, what are the different treatment patterns available, legal decisions, like if at all, if because of these changes, if his personal life is going to get affected, so in that legal decisions also we should take a stand, and changes in lifestyle that will become necessary, and other quality of life issues. So in all these matters you have to take a stand. And I'm coming to this again, this pattern, like modality, type of dementia and evidence. So if the modality is like enjoyable leisure activities per patient preference, so mild cognitive impairment, mild to moderate dementia, then evidence, decreased neuropsychiatric symptoms and functional capacity and slowing of memory loss. So all these will be there. Then we call it as mild to moderate. And mental stimulation programs should be given, like puzzles, word games, past or remnants therapy, indoor gardening, baking. So all these activities comes under mental stimulation programs. So it is also used for mild to moderate dementia. And when these modalities were used, there is improved cognition and self-reported quality of life is also there. And self-reported, the patient itself is saying that there is some change in his behavior and no effect on functional status, mood or behavior. So these include mental stimulation programs like playing puzzles, word games, and past or remnants therapy, like making them to recall all the old memories, indoor gardening, baking. So all this will help in improving their cognition, that is improving their memory. And occupational therapy and training in coping strategies and cognitive aids. So it is also used for mild to moderate. So it also helps in improved cognition. Structural physical exercise programs, structured physical exercise programs. So a few physical exercises also were done. It is also used for mild to severe Alzheimer's disease. It helps in improved physical function, reduce neuropsychiatric symptoms like including depression, slower rate of functional decline. So these were the different modalities. First is enjoyable leisure activities like playing, singing games, like depending on the patient's likes and dislikes. So whatever the patient used to prefer, that should be done. And mental stimulation programs, so which will activate their brain, so which will stimulate their brain or mental activities, that should be done. Occupational therapy training in coping strategies like how to be mingle with other people. So again, if you're giving continuous counselings and all, and structured physical exercise programs, so all this will help in preventing the progress of the disease, and also to cure, and also to make them remember things properly. So these were the different modalities which comes under non-pharmacological treatment. And now pharmacotherapy of cognitive symptoms, we already seen that the first thing is cognitive symptoms, other is like neuropsychiatric symptoms. So in order to maintain this cognitive symptoms, what should we do? Like what are the medications that can be given? So managing blood pressure, cholesterol, blood sugar may reduce the risk of developing Alzheimer's disease. That means if we are controlling the patient who is having hypertension, if you are controlling their blood pressure, controlling their cholesterol levels, controlling their sugar levels, so all this will reduce the risk of developing Alzheimer's disease, and also they will reduce the risk of progression of this Alzheimer's disease. So these should be maintained properly. What are they? Blood pressure, blood sugar levels, and blood cholesterol levels. Okay. And then reasonable expectations of treatment may be slow decline in abilities and delayed long-term placement. Why? Because they require long-term treatment. So we have to clearly explain them that they require long-term treatment. Those who respond to treatment may lose the benefits when medication is stopped. Why? That, as we already know that when this should be taken for a longer duration of time. So if the patient seems after taking medications, he found out that he was very much improved, and as he is thinking that he is improved, if he stop taking those medications, again will come to the first, like again the story will come to the first line. So the medication should not be stopped after the relief of symptoms. So continuously they have to take these medications. So first is cholinesterase inhibitors. First drug of choice is cholinesterase inhibitors. So what are the things what we have to go into when we are using these cholinesterase inhibitors? So when we are changing from one kind of cholinesterase inhibitor to another cholinesterase inhibitor, 1 week washout is sufficient. That means 1 week identification notice is sufficient. So the different cholinesterase inhibitors include donepezil, rivastigmine, galantamine. So these were indicated for mild to moderate Alzheimer's disease, and this donepezil can also be given for severe Alzheimer's disease. So for mild to moderate, we'll be giving donepezil, rivastigmine, and galantamine, and for severe Alzheimer's disease, we'll be giving donepezil. So all these are the cholinesterase inhibitors. And then if the decline in MMSE score is more than 2 to 4 points after treatment for 1 year, so after taking the medications, so already in the last class we have seen what is mini mental status examination. So depending on that score, after taking medication, if MMSE scores decline is more than 2 to 4 points, that means the patient is improving properly. It is so that patient is not improving properly. So in that conditions we can change to different cholinesterase inhibitor. So for example, if we have started the patient on rivastigmine and we have been giving it for 1 year. So after 1 year we'll be checking this MMSE score. So if the decline is if the score is declining if the score is declining more than 2 to 4 points, that means the drug is not properly helpful for that patient. So in that conditions, we can change to another cholinesterase inhibitor, maybe donepezil or galantamine. Okay. Otherwise, the treatment should be continued with, so or else we can continue the treatment with same medication, and we have to check on the course of treatment. We have to again monitor the patient, and or if else it is required, we can increase the dose. And then almost all these three, donepezil, rivastigmine, galantamine, all these three cholinesterase inhibitors, they have similar efficacy. They are similarly efficient. So duration lasts for 3 to 12 months. So because of the short half-lives, as they are having short half-life, so rivastigmine or galantamine treatment is interrupted for several days or longer. Retitrate starting at the lowest dose. So again, we have to retitrate from the starting dose. So the adverse effects include mild to moderate GI symptoms that will be there in every drugs like nausea, vomiting, diarrhea, urinary incontinence. C. Urinary incontinence is also seen because of the patient taking this cholinesterase inhibitor, and also because of this Alzheimer's disease also the patient will be having urinary incontinence. So we have to closely monitor the patient whether he is having urinary incontinence. And dizziness, headache, syncope, bradycardia, muscle weakness, excessive salivation and sweating. And abrupt discontinuation can cause worsening of cognition behavior in some patients. So if you stop this medication immediately, all of a sudden it causes worsening of the condition, worsening of Alzheimer's disease can be seen. So we should not stop the medication immediately. Okay. So these were the main adverse effects. So the main adverse effects include urinary incontinence, dizziness, headache, syncope, bradycardia, excessive salivation. Secretions will be more like excessive salivation, excessive sweating, muscle weakness. So all these things can be seen. We should not stop cholinesterase inhibitors immediately. Like all of a sudden, we should not stop taking these cholinesterase inhibitors. And for severe Alzheimer's disease, along with these cholinesterase inhibitors, we are going to add memantine. So what is memantine? So how does it act? It blocks glutamatergic neurotransmission by antagonizing NMDA receptors. So it will blocks glutamatergic. That means it will stop the release of this glutamate. That is, it will stop glutamatergic neurotransmission. How? By antagonizing NMDA receptors, which may prevent excitotoxic reactions. So thereby it will prevent excitotoxic reactions. Glutamate is an excitatory neurotransmitter. So this memantine will inhibit this glutamate by binding to NMDA and antagonizing the NMDA. It will stop the release of glutamate, which is a neuroexcitatory neurotransmitter. So it will prevent excitotoxic reactions. So it can be used as monotherapy for severe Alzheimer's disease, or sometimes it can be added along with this cholinesterase inhibitor to treat severe Alzheimer's disease. And it is not metabolized by the liver, and it will be excreted unchanged in the urine. So we have to regularly or continuously monitor the drug and the dose in renal impaired patients, or if the patient is having any CKD. If we are giving this memantine, we have to be very carefully monitor the patient. Why? Because the drug is excreted unchanged in the urine, so it may cause some load on the kidneys. So we have to adjust the dose in the patients who are having renal impairment. And the side effects of memantine include constipation, confusion, dizziness, and headache. So it's in some guidelines they were showing that we can give low dose aspirin with with significant brain vascular disease if the patient is having any cerebrovascular disease. So in that conditions we can give low dose of aspirin. And like they were trying to give estrogen to prevent it or treat dementia, but there is no proper support to that trial. And vitamin E is under investigation for prevention of Alzheimer's disease as it is an antioxidant. So, but there is no proper evidence till date because of the incidence of side effects and the lack of supporting evidence. So because of these lack of supporting evidence, neither NSAIDs nor prednisone is recommended for treatment or prevention of Alzheimer's disease. So because of this lack of information, we cannot suggest NSAIDs or prednisolone for the patients even for treatment or prevention of Alzheimer's disease. And statin drugs, even their use is also not shown clearly, but they may prevent the formation of these tangles or no accumulation of fat deposits in the brain. So if you are giving these statins, adverse effects include nausea, vomiting, diarrhea, headache, dizziness, restlessness, weakness, hemorrhage. And poor standardization of herbal products like ginkgo biloba is not recommended for prevention or treatment of AD. Do not use ginkgo biloba in individuals taking anticoagulants or antiplatelet drugs. So for Alzheimer's disease, there is some herbal drugs like ginkgo biloba. So if we are using this ginkgo biloba, we should not take any anticoagulants or antiplatelet drugs. And when you are taking this, we should also we should be very much careful when you are taking a ginkgo biloba along with NSAIDs because this causes bleeding. So you should be very careful when we are taking this kind of herbal products as they are not properly standardized. And Huperzine A has not been adequately evaluated and is not currently recommended for treatment of Alzheimer's disease. Previously it was given, it is also a herbal drug. So here there is a table which is showing different drugs. Donepezil, rivastigmine, galantamine. It is available in the brand names Aricept, Aricept ODT, and 5 mg daily in the evening. Is a daily dose. For mild to moderate, we can increase the dose till 10 mg daily. For moderate to severe, we can increase it to 10 to 23 mg daily in moderate to severe Alzheimer's disease. And it is available as tablet. ODT is nothing but oral dispersible tablet. And it can be taken with or without food. Weight loss associated 23 mg daily dose. If you are giving this 23 mg dose, it causes some weight loss. Rivastigmine, it is available as Exelon patch. So it is 1.5 mg twice daily capsule or oral solution is available. 4.6 mg per day transdermal patch. It's nothing like just like sticker. It will be there like just like bandage. So that is transdermal patch. Usual range is 3 to 6 mg and 9.5 to 13.3 mg per day. So when we are giving this in coming to like special population include moderate to severe renal impairment. So and mild to moderate hepatic impairment or low body weight. So in that conditions we have to consider a maximum daily dose of 4.6 mg every 24 hours. So in that conditions, only this much dose can be given for 24 hours. It is available as capsule, oral solution and transdermal patch. It can be taken with meals. It is also indicated for dementia associated with Parkinson's disease. Even in Parkinson's disease, they will be having dementia. In that case, we can go for this rivastigmine. and application of multiple transdermal patches at same time associated with hospitalization and death. So if you are giving this, so per day only one patch should be kept. If you are keeping so many of patches, it may cause seriousness or and also it may cause death of the patient. And then galantamine, Razadine or Razdan ER, extended release tablets, 4 mg twice daily is available. And next 8 mg daily in the morning, extended release is also available. Usual range is 8 to 12 mg, 16 to 24 mg. For moderate renal or hepatic impairment, the daily dose should be like 16 mg. So in case of renal or hepatic impairment, it is not advisable to take this medication, and it is available as tablet, oral solution, extended release capsule, and it should be taken with meals. An NMDA receptor antagonist, what is it? It's nothing but memantine, right? So it should be given, it is available as Namenda XR, extended release, 5 mg daily or 7 mg daily, extended release capsule is there. For 5 mg daily, it can be given as 10 mg twice daily. For extended release, we can give it till 28 mg daily. For severe renal impairment, the target maintained dose of 5 mg twice daily and 14 mg daily. It is available as tablet, oral solution, and extended release capsule, and it can be taken with or without food. So these were the main drugs like cholinesterase inhibitors and NMDA receptor antagonist, that is memantine. And monitoring drug therapy for cognitive symptoms. So when we are giving these cholinesterase inhibitor, the side effects include these that we have already seen. Monitoring parameters. So we have to report if the patient is complaining of dizziness or falls or changes in the pulse, blood pressure, postural blood pressure change. So all these things we have to monitor while we are keeping the patient on cholinesterase inhibitors. So dizziness is usually mild, it will be there, transient, and it is not related to cardiovascular problems. Routine pulse checks should be done at baseline, monthly during titration, every 6 months thereafter. So every month we have to check all these parameters, and after that we have to check for every 6 months. And nausea, vomiting, diarrhea, anorexia, and weight loss are the other side effects. Weight and GI complaints we have to check. So in order to prevent these GI upset, we have to take the medications along with food. And for a weight we have to consider. So if the patient is complaining of severe GI symptoms, then it's better to go for transdermal patches. Peptic ulcer disease, GI bleeding, signs or symptoms of if the patient is complaining of PUD, who is taking these medications, then we have to ask the patient whether he is having any occult GI bleeding or fresh bleeding in like any vomitings or in stools, that we have to ask. So if it is there, we have to ask the history of ulcer disease or whether he is taking any NSAIDs. And insomnia, vivid or abnormal dreams or nightmares, if the patient is complaining of these things, so at that time we can give this donepezil. Usually we'll be giving at night time. So in that conditions we can give it in the morning to decrease the risk of sleep disturbances. Memantine, it causes headache, confusion, dizziness, and hallucinations. So if the patient is complaining of this, we have to report if there is any dizziness or fallness or hallucinations. And during the dose titration, we have to, why? Because this kind of confusion will be observed normally in all the patients, so it is usually transient, so no need to consider it while titrating the dose. And constipation and GI complaints, so that also will be there. So these were the comments, monitoring parameters, so all these about cholinesterase inhibitors and memantine. And then this is all about pharmacotherapy of cognitive symptoms. Now it is all about pharmacotherapy of non-cognitive symptoms. It includes behavioral changes, psychiatric symptoms, depression. So for that, there are some guidelines. It includes environmental interventions we have to use, and pharmacotherapy can be used only when it is compulsorily required. And we have to identify the causes or reasons behind these his behavioral changes, and we have to treat, or we have to reduce the cause which is causing these changes, and start with reduced doses and titrate slowly. So we have to start with reduced doses and slowly we have to titrate the dose. Monitor closely. periodically attempted to taper and discontinue medication. So slowly we have to increase the dose, and whenever it is used to stop, slowly we have to reduce the dose and we have to discontinue the medication. And whatever it is, that everything should be documented carefully. And avoid anticholinergic psychotropic medications as they may worsen cognition. Why? Because we will be giving for treatment cholinesterase inhibitors, already we are giving. Again, if, along with that, if we are giving anticholinergics, it will further worsen the cognitive behavior. So we should not be giving anticholinergics in combination with cholinesterase inhibitors. And cholinesterase inhibitors and memantine, they showed only little much of changes in behavioral symptoms over time. And basically for any psychiatric symptoms, psychotic symptoms, will be going for antipsychotic. So these were used for disruptive behaviors, neuropsychiatric symptoms. But when we are using these antipsychotics, we have to assess the risk and benefits. If the risk is less and benefits are more, then we have to keep the patient on antipsychotics. And if the risk is more and benefits are less, no need to use this antipsychotics. Adverse events include somnolences, that means always feeling sleepy, extrapyramidal symptoms, abnormal gait, worsening cognition, cerebrovascular events, increased risk of death, offset advantages. So all these were the risk when we are giving these antipsychotics. And another systematic review and meta-analysis found small but significant improvement in behavioral symptom scores in patients treated with aripiprazole, olanzapine, and risperidone. So the antipsychotics that we will be giving in patients who are having Alzheimer's disease include aripiprazole, olanzapine, and risperidone. So they may also produce small increased risk of death. So because and hypotension also can be seen those who are taking these antipsychotics. So they can be continued beyond 12 weeks. Sorry. Antidepressants, depression and dementia both will be having some kind of similar symptoms and the diagnosis, especially later in the course of Alzheimer's disease. So selective serotonin receptor inhibitor, reuptake inhibitor, that is SSRIs, should be given for depression. So basically, the best drug that is used for for depression includes sertraline and citalopram. And tricycline antidepressants should be avoided. And miscellaneous therapies include benzodiazepines is not advised except on as needed. Only whenever it is compulsorily required, then only we have to go for benzodiazepines, or else we should not go for benzodiazepines for agitation. And carbamazepine, valproic acid, gabapentin may be also alternatives, but the evidence is not clear. So these were the drugs. So these were the doses of these aripiprazole, olanzapine, quetiapine, risperidone, antipsychotics, antidepressant, citalopram, and sertraline. So these were the main commonly used drugs, and these citalopram, fluoxetine, mirtazapine, trazodone were also used, but mainly citalopram and sertraline were used. Anticonvulsants like carbamazepine and valproic acid. So these were the starting dose. This is the maintenance dose. And the target symptoms of antipsychotics, the patient should be relieved from delusions, suspicions, disruptive behaviors, agitation, and aggression. Antidepressants, the target symptoms: poor appetite, insomnia, hopelessness, anhedonia, withdrawal, suicidal thoughts, agitation, anxiety. All these should be decreased. And for anticonvulsants, agitation and aggression should be decreased. So this is all about that. About the different medications that can be used for non-cognitive symptoms of dementia. And what were the evaluation of therapeutic outcomes? So at the baseline, the patient and the caregiver both should identify target symptoms. What are the target symptoms that should be decreased initially? Define therapeutic goals. Document cognitive status, physical status, functional performance, mood, thought process, and behavior. And MMSE score should be maintained properly for cognition. Physical self-maintenance scale should be maintained. Neuropsychiatric inventory questionnaire for assessment of behavioral disturbances should be used. That means a few questions should be questions should be framed, and that should be used to identify changes in the symptoms and functioning. Observe the patient for the potential side effects as he is taking these psychiatric medications and neurological medications. So we have to carefully monitor for any potential side effects. So if there is any potential side effects were identified, that should be documented, and drug effectiveness should be identified, side effects, whether the patient is taking medications regularly or not, adherence to regimen, and need for dosage adjustment, whether to titrate the dose or whether to decrease the dose. That should be checked every month, and several months to 1 year of treatment may be required to determine whether therapy is beneficial. So in order to identify whether the treatment is beneficial or not, it may require at least 1 year of time. So this is all about the evaluation of therapeutic outcomes. So with this, we'll be completing the treatment of Alzheimer's disease.